Well, good morning. So the IMPROVE-IT trial certainly is a landmark trial, and it's a randomized clinical trial that really looked at the clinical benefit of the combination of ezetimibe combined with simvastatin compared to simvastatin monotherapy in patients within 10 days of an acute coronary syndrome. Okay, here's my conflicts, which are none. So this study was under the leadership of Eugene Braunwald and Robert Califf. It was a multinational study involving 39 countries, over 1,100 sites. And really, as a background, lowering LDL cholesterol, as we discussed yesterday, has been a mainstay of cardiovascular disease prevention. And really evidence that, mainly from the statin trials, shows that we can reduce cardiovascular morbidity and mortality with statins. However, to date, there has been no lipid-modifying therapy added on to statins that can show a further clinical benefit. And that includes the fibrate trials added to statins, niacin added to statins, and of course the CETP inhibitors. They've all failed to show any kind of benefit, and some actually, as it relates to the Illuminate trial with torcetrapib, showed significant harm. So it really is, as we know, the current guidelines are a statin-centric guideline. And the problem is that despite our use of statins, many patients remain at considerable residual risk. So as a background, ezetimibe is a sterol influx inhibitor, and it acts really by inhibiting the NPC1L1, the Niemann-Pick C1-like-1 protein, which is located at the brush border of the intestinal tract. But since my friend and colleague Tom Dayspring is here, he, I'm sure, stated correctly yesterday, it also has action at the hepatobiliary junction. But its main function is to reduce cholesterol absorption. And when added to a statin, we can get a 20% further reduction in LDL cholesterol. Very importantly, on the heels of the presentation in the American Heart Association meeting, there were two other presentations that were human genetic studies of polymorphisms of NPC1L1 that basically was a loss of function mutation and showed significant benefit for those individuals that had this genetic polymorphism. In fact, this is one of the studies by Stitzel and colleagues that concluded that naturally occurring mutations that disrupt NPC1L1 function were found to be associated with a reduced plasma LDL cholesterol of about 12 milligrams per deciliter, but a reduced risk of coronary heart disease risk by 53%. And of course, that's really because we're reducing atherogenic lipoproteins over the course of a lifetime. And it's this decreasing exposure of atherogenic lipoproteins to the vascular wall that translates into such a significant benefit. Well, the goals of the IMPROVE-IT trial really was to answer really three questions. Number one, does lowering of LDL cholesterol with a non-statin agent, ezetimibe, reduce cardiac events? Number two, is even lower even better? Now, that's, prior to the study, it was estimated that with just the simvastatin arm of this trial, we would get LDL cholesterol down below 70. So now we're saying, are we really going to show benefit by going from an LDL cholesterol in the 60s down to the 50s? Because that's a high hurdle to jump over. And of course, the third question to be answered was, is ezetimibe safe? There were a lot of hurdles that ezetimibe had to jump over Did it cause cancer? Did it interfere with SRB1 receptors and the like? And it really was critical that this trial showed that this drug was indeed safe. So, basically the inclusion criteria of the trial were men and women over the age of 50 or older, who presented within 10 days of a STEMI, non-STEMI, or unstable angina, plus one high-risk feature. Could be new ST segment changes, positive troponins, diabetes, peripheral arterial disease, cerebrovascular disease, prior bypass surgery, or multivessel coronary artery disease. Their entrance LDL cholesterol had to be between 50 and 125. Unless they were already on statin therapy, then it was between 50 and 100, with the major exclusion criteria of prior bypass surgery, or people that were on current statin therapy more potent than Simva-40, or if they had renal insufficiency with a creatinine clearance less than 30, or active liver disease. So here was basically it was a pretty straightforward design where over 18,000 patients were randomized to either the simvastatin arm, simvastatin 40 milligrams a day, versus ezetimibe 10 milligrams combined with simvastatin 40 milligrams a day. And they were allowed to be up-traded to simvastatin 80 milligrams if their LDL cholesterol was greater than 79. Now, this up-titration ended in 2011 when the FDA came out with a warning that simvastatin 80 milligrams could be associated with muscle toxicity. And those patients that were already up-titrated to the 80 milligrams of Simva in either arm and were stable and doing well on it continued on the Simva 80. The primary endpoint of the trial was cardiovascular death, MI, hospitalization for unstable angina, coronary vascularization, or stroke. So here are the study metrics, and if you see, they were remarkably similar between simvastatin and the combination of Simva plus ezetimibe, with the exception of those requiring up-titration. As you can well imagine, more patients in the simvastatin monotherapy arm required up-titration. Otherwise, remarkably similar, as were the baseline characteristics, almost identical. Mean age 64, about a quarter of the patients were female, 27% were diabetics, and you could see how similar all of the baseline characteristics were in both the Simva arm and the combination arm. Well, here we see the results, and you could see a significant decrease in LDL cholesterol at the very outset of the study, which was maintained in both arms throughout the study, with a LDL cholesterol of 69.5 milligrams per deciliter at the end of the trial in the simvastatin only arm, and 53.7 milligrams per deciliter in the combination arm. The one-year mean change in LDL cholesterol was 16 milligrams per deciliter in the combination arm over the simvastatin monotherapy. There was also significant reduction in total cholesterol, triglycerides, with no significant change in HDL or hsCRP. Now, as far as the primary endpoint, in the intention to treat analysis, there was a significant decrease in events. In fact, there was a 6% relative risk reduction favoring the combination arm of simvastatin plus ezetimibe, and a 2% absolute risk reduction with the number needed to treat of 50. And again, the p-value less than 0.05. The on-target analysis showed even better results, with that number needed to treat going down to 38. Now, not only was the primary endpoint met, but all three pre-specified secondary endpoints were also achieved, all significantly, statistically significant, with p-values less than 0.05. If one looks at the individual endpoints of this study, the benefit was largely driven by a reduction in myocardial infarction and stroke, as you can see. And if you look at the pre-specified subgroups, there was benefit in the combination group in all pre-specified subgroups. Male versus female, less than or greater than 65 years of age, diabetic status, prior lipid-lowering therapy, LDL above or below 95 at entry. You could see all these subgroups benefited by being on the combination arm of this study. This is very interesting. This Kaplan-Meier curve comes from the cholesterol treatment trialists collaboration. And basically, the question is, this study that was done was looking at all the prior statin trials, and you could see it confirmed that lower indeed is better. Well, where did the ezetimibe, simvastatin fall in the IMPROVE-IT trial in this? And you could see that looking at the degree of LDL reduction in this trial, it resulted in a proportional reduction in event rate that you would expect if this were just a statin trial. So it basically lower is better. And as long as a drug does not have off-target toxicity and lowers LDL cholesterol, this is consistent with our LDL hypothesis. As far as safety, this drug, certainly there was no safety signals of this trial. Liver function tests, gallbladder issues, muscle issues, including rhabdomyolysis, very importantly, cancer, there was no safety signal. And I point out cancer because for many of you that remember the SEAS trial, there was a cancer signal in that particular study. However, this was repudiated in further analysis of that study, and clearly it puts this issue of cancer to rest. There was absolutely no cancer signal in this major landmark trial. So the conclusion of this study, this was the first study demonstrating incremental clinical benefit when adding a non-statin agent, ezetimibe, to statin therapy, and it did answer the three questions. The first question, does a non-statin lowering of LDL cholesterol with ezetimibe reduce cardiovascular events? The answer is yes. Is even lower even better? We could clearly say the answer is yes. A statistically significant further decrease in event rate by lowering LDL cholesterol from the high 60s down to the low 50s. And the third question is a very important question that was answered. Is ezetimibe safe? The answer is absolutely answered in this trial, and it's yes. Now, this study clearly reaffirms the LDL hypothesis. And certainly, I'll discuss in a minute, the results should be considered for our future guidelines. But if one looks at the LDL hypothesis, I would like to make a little modification of our LDL hypothesis, which has always been that lower is better. And I think that it should be changed to safely lower is better. One looks at trials, again, like the Illuminate trial with torcetrapib. Torcetrapib, a CETP inhibitor, lowered LDL cholesterol. Problem is it had off-target toxicity, as many of you know. It raised blood pressure, did some other things, and therefore that trial was stopped. But if we have, it appears, an agent that is able to lower LDL cholesterol and is safe with no off-target toxicity, it certainly goes along with our LDL hypothesis that lower is better. And certainly we know that in this particular trial, driving LDL cholesterol down to the low 50s was efficacious. But there still are some lingering questions. One of the very important lingering questions as a result of this trial, should we treat moderate to high-risk patients who are outside the improve it criteria. So what are you going to do Monday morning when a patient walks into your office who has had a myocardial infarction and is on statin therapy, say simvastatin 40 milligrams, and you take a history, but the myocardial infarction was a year ago? Does this trial apply to that group? Or should we just be, by using our strict criteria saying that, gee, it's only for patients who are within 10 days of an acute coronary syndrome? Or should any patient who is high risk not be placed on ezetimibe in addition to the statin unless their LDL cholesterol was very, very low? That's what is really going to be discussed. Now, one can say, well, as a purist, let's do another randomized controlled clinical trial with ezetimibe to answer all these other questions in patients with criteria outside of improve it. Well, don't hold your breath waiting for that. Number one, ezetimibe comes off patent in 2 years. So the first question, who's going to pay for all these trials, these 7 to 10-year trials? And secondly, as was discussed yesterday, one of the most important things that we have is our ability to use clinical judgment. When we see a patient, what we have to do is take all available evidence and decide what's best for that given patient. So I think this is going to be discussed at length tomorrow when we have where we discuss the guidelines. But it's my opinion that this trial, this landmark trial, certainly reaffirms the cholesterol, the LDL hypothesis. And if our clinical judgment tells us that a high-risk individual could further be helped with the addition of ezetimibe, it should be used to reduce residual risk. Another question, which is a very fascinating one that was brought up yesterday by Dr. Dayspring, has to do with measurement of sterols. And certainly if one looks at markers of hyperabsorption, and I borrowed this slide from Tom, he showed this yesterday. The problem is that if you place a patient on a statin and that person is a hyperabsorber of cholesterol, as in the 4S trial, they did not benefit from being on the statin. We have a feedback loop. And we know that if a patient's a hyperabsorber of cholesterol, and you use an agent that decreases synthesis, what's the gut going to do? It's going to try to crank up even more absorption. So it only makes sense that it can help further advise us as to who truly is going to benefit from the addition of an intestinally active sterol influx inhibitor. The other question, which is equally as interesting, is that of plant sterols. For many of you that know, there's a hereditary homozygous testosterolemia in kids. Unfortunately, this is a case of a 20-year-old walking to class one day, had a cardiac arrest, no prior symptoms. At autopsy, they found plant sterols in his atherosclerotic plaque. So it clearly, our body does not like plant sterols when it gets absorbed. Why does it get absorbed? Usually from a polymorphism of the ABC G5, G8. So we can leak plant sterols. Now, putting aside the homozygous polymorphisms, how about those of you out here in the audience who happen to just leak a little bit of plant sterols, but you're at upper limits of normal? Well, the PROCAM trial looked at those individuals and they concluded that if you are in the upper tertile of normal and plant sterols, you increase your risk of having a heart attack threefold. And as I started this conference yesterday, stating that what we're trying to do is figure out ways that we could lower residual risk, stabilize plaques, this may well turn out to be one of those other things that we should be looking at. Measurement of plant sterols, making sure that our patients are not in the elevated plant sterol category, because we could do something about it. The other issue is, should we optimize rather than maximize statin therapy in certain patients? And as an example, we could say, what if we have a patient, a 73-year-old frail woman who just had a myocardial infarction, and you see the results of the Improve It trial, but if we go by guidelines, do we really want to take that woman, that frail 90-pound woman, and put her on 80 milligrams of atorvastatin? Well, would it not make more sense to perhaps put her on a moderate dose of a statin and combined with ezetimibe, given this data, so as to not end up with side effects, especially myalgias? And remember, sometimes we only get one shot. Patient ends up with a lot of symptoms. It's very hard to get them to accept and take their statins. So I could think of a lot of different subsets of individuals that may indeed benefit from optimizing their statins rather than maximizing the statin dose at the get-go. And of course, the final question is, should we modify the cholesterol guidelines? I feel that there will be future iterations of our new cholesterol guidelines that will change as a result of this study. We'll again vet this tomorrow. And certainly, I think that we might want to consider return to targets of therapy, given the Improve It trial. And, so stay tuned. I hope all of you are able to attend tomorrow, because I'm sure we'll have a lively discussion. Thank you very much for your attention.